On this episode of 26 Minutes with Dr. Warren Seigel, we are joined by Dr. Frida Popilevsky. We're going to discuss the vital topics about respiratory health, focusing on asthma and chronic obstructive pulmonary disease, also known as COPD. Tune in as we explore the importance of lung health and share insights on managing these common yet challenging conditions. Dr. Popilevsky, thank you so much for joining us today. So happy to have you here.
Thank you.
So tell me a little bit about yourself. Where are you from? What do you do?
Okay, so I was born in Ukraine and I immigrated to New York City at the age of 2. So I have no memory of that. I grew up in Brooklyn. I stayed in Brooklyn throughout my training, my education. I went to SUNY Downstate College of Medicine. For undergrad, I went to New York University in Manhattan. And then I had my residency in internal medicine, my fellowship in pulmonary medicine and critical care medicine, all at SUNY Downstate as well. And then I've been working at South Brooklyn Health ever since.
Wow, long haul for a Brooklyn girl.
Yes.
Glad you stayed in the neighborhood, but it sounds like you've been trained in many, many different areas. You mentioned internal medicine, critical care, pulmonary medicine. What do you do specifically at South Brooklyn Health now?
At South Brooklyn Health, I'm the director of the surgical intensive care unit. I'm the director of respiratory therapy as well, and I do practice pulmonary. So a little bit of everything, but mostly in the surgical intensive care unit.
So in the surgical intensive care, you're not doing surgery. You're responsible for...
I'm responsible for taking care of the patients before and after surgery when the surgeries are high risk, or patients are critically ill and it's related to the surgery when they're quite sick and not well enough to be on the regular medical floors.
Wow, that's a huge responsibility. So today we're talking a lot about lungs and lung health and how we can be as healthy as possible. So one of the things that I've always thought about when we talk about being healthy, asthma is the numbers have just been growing and growing over the years. Do you see a lot of people with asthma?
Yes, asthma it's everywhere. I see a lot of patients. I end up seeing the more severe cases, but certainly I've dealt in a pulmonary office setting with patients who require prevention, a lot of education. We need to speak to our patients more. Asthma is characterized by shortness of breath, cough, sputum, mucus production. It can have many triggers. The triggers can be cold weather, springtime weather, the changes in the seasons. They can be smoke inhalation, pollution, and it runs in families. And the fact is that in the office setting, I found myself spending a lot of time training patients on proper inhaler use, because I found that many of our patients were prescribed medications, these inhalers that they hold in their hand and breathe in, but they don't exactly know how to do it. And interestingly, the figures go as high as 80% of patients really don't know how to use an inhaler properly, and that's why their symptoms are not controlled.
So the inhaler is the treatment for asthma. Is
Right.
there something that we can do to keep from getting asthma, or is it inevitable because it runs in families, and once again I can blame my parents?
Don't blame your parents yet,
Okay.
but it does run in families, and sometimes it's unavoidable to get an asthma flare-up or an asthma attack. But there are ways to avoid asthma flare-ups, and I would say avoiding pollution, avoiding the triggers, secondhand smoke exposure, smoking yourself, it's not good for your asthma. Avoiding sick people. Sometimes viruses are the things that trigger asthma flare-ups. Sometimes you just have to get your vaccinations on time and be on point when it comes to seeing your doctor. You should be vaccinated for the flu, for pneumonia, for COVID-19. Try to avoid sick contacts and wash your hands.
Interesting you should say avoid sick people. I've had asthma since I was a little child.
Okay.
And I have to tell you, the best year for my asthma, which is pretty stable, knock on wood,
Right.
was the year of the pandemic. because I wore a mask all the time. And you're absolutely right. I hadn't thought about it until you were speaking. That was probably the best year of my life because I was wearing a mask. You mentioned pollution. So is asthma more common in cities where we have pollution?
Yes, it appears so, that asthma is more common in cities. However, asthma can also be triggered by your allergies. So you have to figure out what kind of patient you are. What if you're the patient that is triggered by certain trees? So then your asthma might get triggered upstate New York in the woods. It's really hard to say. It depends on you. You have to learn about yourself.
And you talked about smoking, obviously. I mean,
Right.
Everybody knows you shouldn't smoke. That puts you at risk. But you mentioned secondhand smoke. You're talking about being around other smokers?
Yes,
Yeah.
that's a big one for both asthma and COPD. If your parents smoke around you, that can't be good for you. If your spouse is smoking next to you, friends, going into areas where there are many smokers around you, or even smoke, it's left over on the clothing of others, and that can trigger your asthma too. So you have to be very careful about the environment.
So you mentioned COPD, chronic obstructive pulmonary disease.
Yeah.
How is that, or is that related to asthma?
Well, sometimes it can present the same way, so it can be confusing. You'd still have the shortness of breath, and you'd have the cough, and mucus production, and chest tightness. But COPD is a little different. COPD, the number one cause is smoking, and generally it's caused by toxic fumes, toxic gases. Sometimes it can be caused by where you work, occupational exposures, such as the unfortunate people who were at ground zero and then ended up having lung diseases, among them being COPD. And COPD is different because, when we do our breathing studies called our pulmonary function tests, we do see different types of results. It's more of an irreversible damage, as opposed to asthma, which is reversible if controlled. And then, of course, if you don't control it over years, it becomes irreversible. But for the most part, it's reversible as opposed to irreversible in COPD.
So that's interesting. So I never really thought of it this way. So you can have asthma that is controlled, and you do fine. But asthma uncontrolled can develop into COPD?
Yes.
So it's kind of a spectrum of
Over
the same
years.
disease?
Over years, yes, because if you can imagine that the damage is just occurring over and over, and that damage is inflammation, and these inflammatory cells collect in those areas and cause scarring over time. And the scarring over time just shows you that these patients don't get better.
So is the diagnosis similar? Do you make the diagnosis of asthma similarly the way you make the diagnosis of COPD, or is it different?
Slightly different. So for the most part, the screening tests are similar. General practitioners will often have this available, a spirometry test. A spirometry test is essentially a tube. The patient breathes into it. They take a very deep breath, and then they exhale as fast as possible. It's attached to a machine, and that machine measures how much breath they can blow out at a given time and how fast they can do it. And if something abnormal is detected, they could have asthma or COPD. At that point, we give them an inhaler. They take that, and then they do the test again. And based on that, we see if that abnormal value is reversible or not reversible. If it's reversible, it's likely to be asthma. If it's irreversible, it's likely to be a COPD. Of course, we need more detailed testing like pulmonary function tests, and at that point, your general practitioner might refer you to a pulmonologist, a lung specialist, to do that further testing and take a look. But initially, that screening test is very important and can really be done almost anywhere.
So when you say a general practitioner, are you speaking about an internist, a primary care physician, nurse practitioner?
That's correct.
It's a test that anybody can order?
Yes, actually.
And it doesn't sound very painful.
No, it's simple.
Breathing is easy. I've been doing it for years, right?
Exactly.
So why aren't more people getting those tests? Is it like a colonoscopy that you should have every 10 years, or is it only if you have symptoms?
So that's an important question, Dr. Seigel, because it's available. I think patient education is very important, and I think people are just not aware. And also, you mentioned something very important. If you don't have symptoms, you still need the test. Early stages of COPD are actually without symptoms. Most patients say they don't have symptoms in the early stages. And at the same time, if you don't treat COPD, if you're not aware of it, it progresses. And it can progress much quicker if you're not aware of it and not treating it and not avoiding those triggers that are making it worse. So I think it's important to pick it up at early stages when you don't have symptoms. And asking around for the test, who do you ask? Well, it depends on who you're seeing, who your primary practitioner is. But I think you can be referred, anyone can be referred.
So can you have COPD without ever having had asthma? You mentioned people at ground zero. I understand
right.
that. You know,
So you can have COPD. Is your question more, can you have COPD without ever having had a risk factor, a trigger that you know of?
Exactly.
Yes. So interestingly, we have a very mixed population in New York City, right? And so we have immigrants from all different countries, and some third world countries are still using coal-burning stoves, wood-burning stoves, and these are screening questions that we ask our patients sometimes as pulmonologists. And what we find is that the patients that were using wood-burning stoves, coal-burning stoves, are more likely to have COPD than others and not be aware of it in the early stages.
That's really interesting. That just brings home the importance of the environment and what's going on around us.
Yes.
I know there's been a lot of discussion in New York City about gas burning stoves versus electric.
Right.
That's really very, very interesting. So you mentioned how to make the diagnosis of asthma. How do you diagnose COPD? You said, is that the same spirometry, or is it more complicated?
Can screen the patient, and then of course we'll do a pulmonary function test when they're referred to a pulmonologist, same as asthma. But with COPD, there are often other tests. From the asthma side, we look at allergies, right? What might be their triggers? From the COPD side, sometimes we get imaging studies like chest x-rays, sometimes CAT scans, because if you have COPD, you're at increased risk to have lung cancer. So we'll use CAT scans as a screening tool. You are also at higher risk to have oxygen deficiencies. In other words, patients will sometimes have low oxygen levels with advanced COPD, and we'll recommend that certain patients buy something or get referred to get something, a little device called a pulse oximeter, which they put onto their finger, and it measures their oxygen saturation, their oxygen levels, and this can determine whether they need supplemental oxygen or not. So COPD is a little different in terms of where we might direct you.
Is there a treatment for COPD, or is that kind of like, in the stage, you're in trouble?
No, actually, there are treatments available for COPD. I would say it goes into 4 categories. The first being medicines. So we have inhalers that are available to make patients feel better in the moment if they're having this flare-up of a shortness of breath or mucus production. Some patients find that they have to use several inhalers at the same time. They're all different, and there are indications for when to use more than one. When patients have a flare-up of COPD, they need antibiotics sometimes, steroids. And then the second category of interventions for COPD would be pulmonary rehabilitation. Sometimes patients need to be referred for rehab. And what does rehab mean? Well, strengthening exercises, building muscle, building endurance. Because if patients feel better and if they're stronger overall, their COPD symptoms are better.
This is very, very interesting, but I'm concerned. I'm confused. I thought asthma was reversible, COP was not reversible, and yet you're telling me you use the inhalers and I'm going to feel better if I have COPD.
Yes, so you can feel better. I'm not going to reverse your lung function. What I'm going to reverse are your symptoms somewhat, and what we're trying to do is avoid progressing to worse. So we can keep you around longer and keep you healthier longer and more active for longer periods of time, which I think everybody wants a good quality of life for as long as they can have it. And we can do that with all of these interventions. And then there are, of course, oxygen therapy and surgical interventions. So there's lots of options for all different cases. And people feel better. I can't fix their lung, but I can make them feel better.
And the truth is, if you feel better, that's better.
Of course.
Even if you have nobody wants a diagnosis, but you certainly want to feel better given your diagnosis. You mentioned pulmonary rehab. Rehab, I think of exercise. How do you exercise your lungs?
Well, exercises your lungs, but also sometimes pulmonary rehab is about teaching patients how to breathe, how to expand their lungs by using certain positions, certain ways to hold the mouth in order to breathe easier and work through a flare-up. So it's exercise in the way you and I understand exercise, but it's also certain behaviors and certain positions to enhance their breathing.
So that exercise doesn't treat your COPD. It makes you feel better.
Yes.
And does it slow down the progression?
Absolutely.
It
can.
It keeps it from getting worse.
Yes.
Wow. So once again, I think I say this just about every program. Early screening,
Yes.
early diagnosis leads to better prognosis because it increases and improves your quality of life. Are there other things that people with COPD should know or do to improve their quality of life?
Stop smoking. I mean, I can't stress it enough. Stop smoking, stop smoking, stop smoking. I think it's worth saying it 10 times. The smoking really damages your lungs and it makes the progression that much faster. Stop vaping. So vaping hasn't been around long enough, and a lot of people are using it to substitute for smoking, thinking it's safer. The truth is, it hasn't been around long enough, so we don't know a lot, but we know some things coming out slowly. We can't really relate it to causing COPD, but we can definitely say it's worsening your COPD. And then there are certain chemicals found in the liquids that go into the vape, such as diacetyl and formaldehyde, and these chemicals are known to cause lung damage in other ways. They've already been documented. So vaping is another one. Wash your hands, no sick contacts, try to avoid getting sick, similar to asthma. Get your vaccinations on time, flu, pneumonia, COVID-19, and take care of yourself, stay active.
I have to ask, we see more and more states legalizing marijuana.
Yeah.
Do we have any data on cannabis use and COPD, asthma, respiratory problems? Do we know?
Yes.
Do we know enough about it yet?
So again, more and more is coming out regarding this. It's more in the form of case reports, but it seems that smoking marijuana is also toxic to your lungs, can cause lung damage, significant damage. There have been lung transplant patients as a result of marijuana smoking. So yes, we have to pay attention to all of these things, and the information is just coming out more and more. So
as it sounds to me like we're talking about a cleaner environment, not having the pollutants in the neighborhood that we're breathing in, not intentionally putting cannabis, vape, and all the chemicals and all the things that we get from cigarettes into our lungs. Are there other things that people can do to stay healthy, either keep from getting COPD or treat their COPD?
Early intervention, as you said, I would say early intervention, screening for those that don't have symptoms, as crazy as that sounds to some people, when they don't feel anything at all. But knowing that if you had the exposure to smoke in the past, if you worked in environments where you think that you inhale toxic fumes, you should get screened for COPD, and working on bettering yourself. Also, eating well, healthy lifestyle, that's good for anything, and it's good for COPD as well, because if you are obese and you have COPD, well, you feel worse, right, than not being obese and having COPD. So it's about all the choices that we make on a day-to-day basis.
You mentioned asthma and allergies, and we know that there's an allergic component and a genetic component for allergies. Is there a genetic component with COPD? Is this the kind of thing that runs in your family?
So, very good question. Generally, no, but there is a type of COPD that has a genetic basis. It's something called alpha-1 antitrypsin deficiency. This is a protein that's made by our livers, and it's there to protect us and protect us from lung damage from the toxins that we breathe in. Well, there's some patients, very small percentage, there's some patients that actually have low levels of this, and we have the ability to replace that, but we would have to check on a blood test. So if we didn't check you, we wouldn't know.
And is that the kind of blood test that people get regularly? Or?
No, it's for screening for COPD. So usually we'd have to test that we'd screen you, and then you'd come up positive for COPD, or at least early stages, and then we'd test you for alpha-1 antitrypsin, just to make sure that we're looking at everything.
I'm still stuck on this whole idea of getting a test when I feel perfectly fine. Yeah. It's just, and I just can't imagine going to a primary care doctor who says, oh, you need this test, even though you feel fine. Although I guess we do that with blood tests. We do that with other screening tests, right?
Yes, we do, but we don't talk about this one. You know, we do mammograms and we do colonoscopies and we do so many things, but we don't talk about spirometry.
Yeah, very, very interesting. Why do you think that is? I mean, is it a matter of doctors not being educated? Is it a matter of my insurance company not paying for it? Or, I mean, why should I have to ask for it?
So, I think insurance companies do pay for this. I think doctors know about this. I think bringing it to everyone's awareness by having these conversations that we're having today, by perhaps putting up some bulletins around in primary care offices and making it well known, I think just reminds people to do this.
And again, I think you said, I want to make sure this is correct, that my primary care doctor can do this. I don't need to see a pulmonologist.
Yes,
I don't need to see a critical care specialist in the surgical intensive care unit. You've got other things to do. Tell me a little bit about what you do on a daily basis for patients who are coming into a hospital, any hospital, and they're after surgery. If they have COPD, how much more difficult is your job because of that?
Oh, it adds another element to everything. So generally I see patients, I would say the typical patient of mine is after an emergency surgery. And that emergency surgery generally involves something happening in the stomach, in the bowel. And if patients have COPD, sometimes it's more difficult to get them off a ventilator after the surgery. Sometimes the rehabilitation process is harder because they're having difficulties breathing. Sometimes they have their exacerbations or flare-ups after the operating room, completely unrelated to the surgery that they're having. So yes, it just adds another element of difficulty. It's not impossible to deal with, but it's something that we really have to pay attention to, and we address very differently than patients without COPD.
Yeah, you know, it's interesting. We again, another example of parts of our bodies that we just take for granted. You know, nobody, thinks about their lungs until you can't breathe.
Until they can't breathe, right?
Having had asthma my whole life, I mean, it's a horrible feeling when you're having an asthma attack. Thank God I have not had one in many, many years because I take my medication. The things you've talked about, staying away from cigarette smoke, not just cigarette smoking itself, but second and third hand cigarettes, staying away from vaping, staying away from all the toxins that we put into our lungs, whether it's pollution in our cities or from our stoves, etc. You also mentioned obesity and exercise as a way of improving health and lung function.
Yes.
Are there other things that you want to tell our viewers what they can do to make your job easier and make all of us healthier?
So if there's one piece of advice as somebody that I can give people as somebody who practices critical care, it's that when you're unsure, call a doctor. And I tell that to people in the hospital as well, who consult the intensive care unit. When you're unsure, just call us. Because when you shy away from calling us, then we can't address something that might get very serious. And I'd rather come in earlier and say, okay, why don't we try this, rather than coming in later into the situation when things might be too late sometimes. So I'll say the same thing for COPD. When unsure, call a doctor. You know, with asthma, for example, going back to asthma, there's something called an action plan. Okay, an action plan is very important in asthma. It's essentially a list of instructions for patients, what to take every day, what to take when you're not feeling well, and when to call a doctor. And this is important because you pick up on something that feels unusual to you. You know, it's very easy to know when you really can't breathe, then you're calling an ambulance. But as a patient, it's very hard to know when to get attention from someone when your cough is just different, or you're a little more short of breath than you were, but you're not sure if it's worth mentioning, right? But these things progress without someone intervening. And so the best advice I can give is call us early. You're not bothering me.
And the other thing that I think was so important that you said is see your primary care doctor and get your vaccines.
Yes.
Whether it's your flu shot, your
Yes.
COVID vaccine, whatever vaccines are necessary. Again, that conversation goes back. It starts with your primary care doctor. And what I really loved is that you don't wait until you have the symptoms. Try and be as proactive as possible. It's
Right.
wonderful advice. And I want to thank you not only for what you do every single day,
Thank you.
but thank you for taking time out of your busy day to be on the show.
My pleasure.
And that brings us to the end of our program today. We thank you for tuning in and learning alongside of us. For more information about our show, please call 718-510-2103 or visit www.zormed.com. Stay updated and engaged with South Brooklyn Health by visiting us online at www.nychealthandhospitals.org/South-Brooklyn-Health. This broadcast was brought to you by Brick Media in partnership with South Brooklyn Health. For now, stay healthy and stay well.